So my name's Emily Thompson. I am a transplant surgeon and a clinical lecturer based here in Newcastle. I've been involved in this research for about 10 years now, and I am the chief investigator of the study.
I'm Neil Sheeran. I am the Professor of Nephrology at Newcastle University. I've been involved in the work that's led up to the 6-Gene project. For the last 5 or more years, we've been working on ways of improving the quality of donor kidneys before they're implanted into the recipient.
My name's Colin Wilson. I'm a Professor of Transplant Surgery based here in Newcastle. I've been working in transplant surgery for 25 years now, and I perform liver, kidney and pancreas transplants as well as surgery for cancer. So the problem we all face across the world at the moment is that populations are living for longer, and as they get old, they develop a number of different conditions. So it's not uncommon now for people in their 60s and their 70s to have 2 or 3 different conditions. And these conditions could be high blood pressure, being slightly overweight, and diabetes, and cumulatively those exert a lot of pressure, particularly on the liver and the kidney.
Chronic kidney disease is increasingly recognised as a public health global problem. We know that about 10% of all adults have some form of kidney disease, which means that the kidneys are no longer cleaning the blood as effectively as they should. Now, if you look at that, that means that about 700 million people across the globe are living with some form of kidney disease. Data coming out from the World Health Organization would suggest that about 5% of people are dying because of kidney disease. So this is a huge public health problem. Now, it's currently ranked as about the 10th biggest killer of people worldwide. But with the increasing rates of kidney disease that we're seeing, it's expected that over the next 20 years or so, that may rise so that the kidney disease becomes the 5th highest killer of people worldwide.
Kidney and liver disease is a huge problem globally, in the UK, in the Western world particularly, and that's because our patient population are getting older, fatter, more unhealthy, more chronic health problems, and all that over time injures the kidney, injures the liver, and that means more people go on to develop kidney and liver failure, and eventually they might need transplants.
And the treatment for kidney failure is dialysis. Dialysis is where the blood is cleaned, and that can be in a blood cleaning machine, a dialysis machine in a hospital or at home. But that's 3 times a week for 4 hours a day. You're chained to the machine. And it's not as good as kidneys. You end up with functioning at one level, but not the best level. The optimal treatment for people with kidney failure is not dialysis, it is transplantation, because that gives them the full organ function, all the different things that the kidney is doing to help people have a good, healthy life. And also, it separates them from the machine, so you can go abroad, you just have to take some anti-rejection medications with you. But transplantation is very easy to live with. Dialysis is not easy to live with. In the United Kingdom, each year about 7,000 people are waiting for a transplant. The vast majority, 5,000 of those 7, are waiting for a kidney transplant. We do about 2,700 kidney transplants per year. But of course, people are coming and going from the list, and we never transplant in the UK the entire waiting list per year. That's what we're striving for, is if we can really transplant everybody within a year of being put on the waiting list, then their quality and quantity of life would be better. And we know from population studies that that is theoretically possible if we can utilise all the organs that are available for transplantation. The problem is we just don't have enough organs that we can transplant currently, and that's what we're trying to do with this project, is to both maximise the number of transplants and make sure that everybody can get a transplant when they need it.
Organ transplant is when your organ no longer works and we need to replace it with a better one. So in kidney disease, it's when your kidneys no longer filter your blood and the toxins build up and it makes you feel really unwell. And so it's when patients get towards dialysis that we often have to consider transplantation. So the average length of time that people wait for a kidney is 3 years, but it's patient dependent. So some people might get a kidney sooner than that, but some people can wait 5 to 10 years. And that's a really difficult period of time in their life. They're on dialysis, waiting for a call, and patients find that really hard.
So the burden of being on dialysis is quite significant, and all studies have shown that people on dialysis have a poor quality of life on the whole. And that's why we look for transplantation as the best outcome for people with end-stage kidney disease. It removes the burden of dialysis treatment and improves the quality of life for people with kidney disease. Perhaps just to give some idea of what that means within the UK. In the UK, we've got about 30,000 people currently on some form of dialysis. So as well as affecting the individual and having a negative effect on the individual, we've also got to consider what that means to the NHS, because dialysis is a very expensive treatment. It costs approximately £34,000 per year per patient on dialysis. And that's quite recent data from a Kidney Research UK health economic assessment that was performed. That means that the NHS spends about £7 billion per year on the provision of treatment for people with kidney failure. So a huge amount. Now that's direct NHS costs, so actually what it costs the NHS to provide care, which is over £6 billion. And then the remaining costs are the impact that end-stage kidney disease and kidney failure has on the individual's ability to contribute to society. So if you're going in for dialysis 3 days a week, you can't go to work. So there's a significant cost there to society of kidney failure. And this is why really we have to think of kidney disease and kidney failure as a real public health problem. And it's not a static problem. The numbers of people on dialysis are increasing. So although the cost may be £7 billion now, it's estimated that in the next 10 years that amount could double up to £14 billion. And that currently represents somewhere between 3 and 4% of the total budget of the NHS spent just on treating kidney disease.
So the 6-gene signature test was developed in liver transplantation by our team. It looks at a panel of 6 proteins that are involved in inflammation, repair and regeneration. So we've shown that these 6 genes are critical for determining whether or not that liver can be transplanted when we have it on machine perfusion. And what we're hoping to do is take this test also into kidneys. And we have some preliminary data that shows that this same test works for kidneys, but we need to validate that in a bigger cohort. And then we want to apply it to how our therapies are working on the machine. And so this test helps us increase the number of organs by increasing the availability, the utilization and the quality of the organs. And it will help us determine after we've reconditioned them whether they are safe to transplant or not.
So this project has been developed over a number of years, and back in the beginning I started working on looking at molecules within organs that had been donated for transplantation. What we noticed was that the organs that were inflamed or that had inflammation as a result of oxygen deprivation were the ones that didn't do well. And on that basis, we developed this test, the 6-gene signature.
So I've been involved in the work that's led up to the 6-gene project, and for the last 5 or more years, we've been working on ways of improving the quality of donor kidneys before they're implanted into the recipient. So the 6-gene signature is almost an extension of that work, looking at ways of assessing the quality of the kidneys that we've given novel treatments to ensure that they meet a sufficient quality to allow them to be used for transplantation.
So at the moment we have only subjective tests really of whether or not an organ is viable for transplant. And the risk with tests like that is they're open to bias. Everybody has a different appetite for risk based on their previous experiences with maybe the last 100 kidneys that they've transplanted. And that adds in variability across the country, from centre to centre, from surgeon to surgeon. And so by adding in a much more objective measure, then it helps as an aid there. So we're not proposing that this test is going to override the surgeons, but it's something that they can then use to help in their decision making.
So what we're looking to do is to deal with the burden of kidney and liver disease by replacing those organs that have failed with organs from somebody else. Now, the trouble is that the donor's often been affected with these diseases as well. So not only do we have to treat the organs, but we have to make sure that they are going to work both in the short term and the long term in the recipient. So for kidneys, there's a matching that goes on the basis of molecules on the cell surface and how they're going to be recognized in the recipient. Rejection is the critical issue for kidneys. But beyond that, there's this quality issue, and more that is coming to the fore. So focusing on kidneys, it's about how much damage has been sustained. And again, this is where the test that we're developing comes in, is to assure that this kidney is going to work in the recipient.
So at the moment, we look at 6 different genes in the test, and that is a series of inflammatory cytokines and proteins involved in repair and regeneration. And that is IL-5, IL-15, IL-12, IL-16, CRP, and VEGF. But we're looking to actually include some more genes and more proteins in this panel, especially as we move from liver to kidney, because it may be that there's other things of more importance. And we've got some research that's shown that already. So we're hoping to expand that. So the presence of the proteins, so we test them at the moment in the blood that's being used during machine perfusion or in the preservation fluid that's flowing around the organ. And it's a marker of how injured that organ is at the point of donation before it's transplanted. And so we know that having these markers up can be a bad thing, but it can also be a good sign for some of them that the repair and regeneration process might be able to take place after it's transplanted.
We hope at the end of this project we will have a test, or more likely a battery of tests, that we can apply to a kidney to show that our intervention has worked and that the benefit of that intervention persists and moves kidneys that have perhaps previously untransplantable to a position that they're transplantable, and to make transplantable kidneys better. This will not be for all transplants, because many transplants will be very good anyway, and we won't need to apply these therapies. They can be transplanted straight away. But it's those kidneys that there's uncertainty, the more marginal kidneys, that these sorts of tests, these sorts of therapies will potentially be very beneficial for. And that's really the focus of this project. The ultimate aim will be that in the future we can take these possible marginal kidneys, give them a treatment, apply the test, say that the treatment has worked, and that kidney can then be used. That means that we can do more transplants, we can get more people off dialysis. And that's really the ultimate aim of all transplant research, is to get more kidney transplants performed and get those kidney transplants to last longer.
So one of the ways that we see the 6-gene signature test really being beneficial is that it's a rapid test. So we can get the results of this test at the moment within an hour to 2 hours. Time is really critical in transplantation. So the minute the organs are out of the donor, the clock starts ticking. So we can't look at tests that are going to take 2 weeks to give us an answer, because by then we need to have transplanted that organ. So this test will give us rapid information that can change decisions quickly. So if we're able to show that this test really does determine whether or not an organ is transplantable, then we hope to develop a point-of-care rapid assay that anyone who's doing this type of research and transplantation could do. And the point-of-care test is something that can be done at the bedside or at the organ side in this situation, and so they would get real-time results.
We think, looking at the numbers, we could do 1 extra kidney transplant a week. That's not just in one centre, that's across the whole country. And that sounds like nothing, but actually if you add the numbers up, so 50 transplants a year, 100 transplants in 2 years, if you get to 10 years and you're doing 1 extra kidney transplant a week, you actually save the healthcare system £100 million at 10 years.
Our group in Newcastle here are very sort of committed to trying to move this area forward into clinical trials, into clinical applications. We do recognise that a lot of things that are produced in the laboratory don't get to that stage, and we've ourselves have generated some really exciting, interesting data, and we're really focusing on now how to move that into clinical studies where this test would be used. to then show that we can do more transplants and we can transplant better kidneys. And if we can achieve that, then we've really made an impact in terms of improving the outcome for patients.